All right, welcome everyone to this presentation. My names are Daniel Wandila, pharmacist at Link Pharmacy, Mokowamo in Kitwe. I'm very excited to share and revise with you on this interesting topic titled Management of Migraine. I'm sure each and every one of you will agree with me that migraine patients are amongst the commonest clients that visit our different sites in our daily operations. As such, I feel it is imperative that we have the knowledge of this condition on our fingertips so that we can serve our patients or rather clients uh, much more effectively. So basically, to discuss this topic, we are going to outline it as follows. Firstly, we'll talk about the definition. We need to understand what migraine is. Then we'll discuss a few points on the etiology and say something about the pathophysiology. We'll then talk about the causes, or others would prefer calling them triggers, symptoms, and then we can classify migraine. We'll now talk about the main braid, which is the management of migraine, both the non-pharmacological interventions and the pharmacological interventions. Then we'll conclude the topic and references will follow. I'm sure in few days quiz will follow up. I don't mean to bother you with a detailed or molecular level explanation of this entire topic. It's just a brief summary just to refresh the knowledge that we already know. Um, Basically, by definition, migraine is actually defined as moderate to severe headache felt as pounding pain, usually on one side of the head. That's a classical definition. Throbbing pain, usually on one side of the head, though it can occur on both sides, but the classical definition is unilateral. Or we can go a little bit scientific and describe it as a neurological disease which is characterized by some recurrent episodes of throbbing or pounding headache, mostly unilateral, and it is accompanied by other uh, sensory symptoms, which might include nausea, dizziness, and in some cases, vomiting. So, to current date, the exact cause of migraine is unknown, though the current state of knowledge uh, relies on the theory that it is actually it actually comes as a result of some disturbances in the aminergic brain cells, which results in different effects such as nerve activation, uh, imbalances in chemicals, and then blood vessels dilatation. It is a genetically inclined condition, and it is very much common in females than males. In fact, the ages of 15 to 35, it is 3 times more common in females than in males. We'll get to understand why it's like that as we move on. But points to take from here is that uh, migraine comes as a result of changes or imbalances or disturbances in the aminergic brain cells that is in the brain, and that results into activation of nerve signals, and there's some chemical imbalances, chemicals such as the neurotransmitters, one of which is very common or one that is more inclined to it is serotonin. So an imbalance in serotonin has been actually associated to be amongst the causes of these imbalances in the aminergic cells that results into the irritation of blood vessels. So the disturbances that occur actually within the brain cells results into a complex of effects. The most common one being pain, and then others, if other symptoms include nausea, dizziness, some visual disturbances in other people, fatigue, mood change, also some cognitive symptoms that would result into imbalance in terms of movement. Polyuria is also one of the symptoms. Yawning in other people occurs, that is prior to the actual attack of the migraine itself. It is very important to understand that these disturbances that occur in the brain, they come as a result of either genetical changes or hormonal changes or environmental changes. It might be psychological, or they could be drugs or the food that we consume. So to understand what other people would call causes of these changes in the brain, that would cause the changes in the brain cells, for the sake of this discussion, we've grouped them into uh, hormonal, dietary, beverages, psychological, environmental, sleep-related, and drugs. So under hormonal triggers, basically what happens is that during the different times of the month, especially in the female folk, you realize that there are always these fluctuation or changes in the hormones, the main hormone being estrogen. The fluctuations in the levels of estrogen in the body results into different changes also in the brain cells, and this usually occurs during menstruation, ovulation, or ladies that are taking oral contraceptive, or those that are on hormonal replacement therapy. Under dietary, products that have got a high content of nitric oxide, nitric oxides such as nitrates laden meat, or products that have got monosodium glutamate, that is a preservative, and the common sweetener aspartame, chocolate, cheese. These products have got a tendency to increase the levels of nitric oxide, and as we know, nitric oxide is responsible for vasodilatation of most of the blood vessels, and the blood vessels in the brain are not an exception. Beverages such as caffeinated beverages, such as those commonly known as energy drinks, have got high levels of caffeine. Beers, wines, especially red wine, those are major culprits that would trigger one to have migraine headaches. Psychologically, the main cause of migraine headache is stress, both at work and at home. Anxiety and depression would also be the main factors that would trigger a migraine. Under environmental triggers, the glaring and flashing lights are the commonest. Places that have got the lighting that is in alternating manner, such as in clubs and in discos. They are amongst the environmental places that would trigger one to have a migraine. Also, strong smell of certain fragrances would, in other people, trigger some migraine. Attitude, weather changes, all those in other people, they have that tendency to trigger the migraine. Not in having enough sleep or having excessive sleep in other people has a potential to trigger a migraine. Drugs which contain nitric oxide, such as nitroglycerin, or those on oral contraceptives, drugs like agorazine, ranitidine, and estrogen, all these have a tendency to actually make changes in the aminergic brain cells, thereby disturbing the normal functioning of these brain cells, and they result into someone being triggered to have a migraine. What are the symptoms of migraine? A classical definition or a classical differential of migraine is having a throbbing headache which is unilateral. This can be accompanied by either sensitivity to light or sensitivity to sound, or nausea, dizziness. In worst cases, it could even be convulsion. Also, some numbness in certain parts of the body. All that can be encompassed together and present as migraine. Sometimes you don't really need to have all these to describe it or to differentiate it as migraine, but just one, which is mainly throbbing headache, combined with any of these symptoms. Under classification, don't worry about this overcrowded slide. It's just a copycat of the classification of migraine by the International Headache Society as at 2014, where they described the migraine in different ways, but mainly two came out as the main umbrella of the other classification. That is migraine without aura and migraine with aura. So migraine with aura has got some subdivision with it, depending on either the location or the onset or the part of the body that would have been like associated with the migraine itself. So from here, the only 2 points that you need to take are that migraine is divided commonly in two: migraine without aura and migraine with aura. The other ones are subdivisions of the two. So just to highlight what I'm explaining there are two common classifications of migraine as the main important ones, because the first one occurs in about 75% cases, whereas the other one is about 1/3 of the cases, which means that entirely about 99, 90%, 99, 98% of all the migraines, they fall under these two. Therefore, we are going to stick to these two as our commonest classification. So what are these two common classifications? The first one is migraine without aura, which is a common migraine, and then there is migraine with aura. I'll explain to you what is the differences between these. Okay, so migraine with aura is actually what is different, which is described as classic migraine, Why is it so? It's because, firstly, it has what is called a prodromal phase. A prodromal phase is actually a phase where there is a sequence of different alterations or changes to somebody's body before they have the actual attack of the migraine. Meaning, there are some warning signs, there are certain steps that the pattern follows before the main attack comes in. It is actually these alterations, these changes prior to the actual attack that are referred to as aura. So what are these changes? These changes include vision alterations. This is where a patient might describe seeing flashing lights or zigzag lines, or a patient might be experiencing some tingling or numbness on one side of the body, either on the hip, on the fingers, or on the face, or just one side of the body. So they will definitely have such signs prior to the unilateral headache. They might have nausea prior to that. As they are experiencing, they might just have one or a combination of these symptoms that I've just described. They could be seeing some flashing lights with nausea, or they can be seeing zigzag lines, then nausea follows, or they can just be having a tingling or numbness sensation on one side of the body. Then few minutes later, headache follows, and headache is usually unilateral. Like I mentioned, vomiting might occur in other clients. In other clients, there'll only be nausea. And mostly, one only gets relief from this type of migraine, especially the first stages, the same prodromal phase, by laying in a dark and quiet room. It is actually 3 times more common in women than men. Then we come to common migraine, which is migraine without aura. So migraine without aura has got no warning. There are no alterations prior to the attack itself. And that is the main difference. There is no prodromal phase. It is the commonest because you find most people, I just woke up, I developed a headache. I was just okay, but suddenly I've got a headache. And the headache is on both sides of the head. So the pain actually is on both sides of the head, unlike in the migraine with aura, where it's only one-sided. In common migraine or migraine with aura, nausea and vomiting may occur, or it may occur, and then other signs, of course, the sensitivity to light and sound may also occur, which is actually the most common type of migraine. So on this slide, we're just trying to make a few comparisons between these two types of migraines. So we are looking at the frequency in attacks. In migraine without aura, which is common migraine, it attacks people at least 5 times per year. It can be 5, 10 times, 20 times, but at least it is the minimum is usually 5 times per year. Whilst in migraine with aura, the attacks only happen at least twice in a year. Duration is between 4 to 72 hours, and then for migraine with aura, it's as usual, the symptoms are gradual, and then it can just be there for 60 minutes. Those aura symptoms subside, and then you might have an attack, or if you manage it early as it's giving you signs, it can't even lead to that particular attack. Nausea and vomiting, they can occur in both. But one point to note is that The pain usually in migraine without aura is aggravated with physical activity. So if one has that migraine without aura, activities such as climbing stairs, doing physical exercise to a certain extent would actually aggravate the pain. All right, so we come to management, which is our main braid for the day. So how is migraine managed? So as I mentioned, we're going to group the management of migraine into non-pharmacological, that is where no drugs or medicines are required. What is it that one can do to manage migraine? So the first point to note is that migraine can be prevented and migraine can be handled before it reaches the most severe stage. So when you are visited by a client and then the client is complaining of a migraine that is uncontrollable, maybe she talks about the pattern that has been recurrent or it's been severe. I've used quite a number of medication, but the migraine does not go, or it goes but it keeps on recurring. The first thing that you have to do is you have to advise the client to make observation of the potential triggers, because it is from the triggers where you can come in to make that suggestion that would help the client to stop experiencing whatever they are experiencing. So the first point note is advise the client to be able to observe the potential triggers, and they can manage to do this by actually coming up with a diary called a headache diary. In this headache diary, the client or a patient is supposed to be recording the onset and the severity of the migraine. Which day did this particular event happen? They keep on recording in a diary, so that in a space of 1 month, 2 months, 3 months, you are able to analyze that particular data, and it is going to help you point out what exactly could have happened for those events to have occurred. So you have to be referring to those triggers that were mentioned earlier on, to do with the hormonal, the dietary, beverages, uh, the sleep patterns, the drugs, etc. So if you are able to isolate or figure one or two triggers from there, that becomes an intervention point, and that would be very much helpful to the client, because that would help them to refrain from the triggers, hence reduce in the occurrences of those migraines. So after analysis, definitely you have to make lifestyle modification. For those that drink certain type of beer, you can advise uh, based on the same. Those that have got problems with sleep patterns, you might advise likewise. Those that are under stress, help them undergo stress relaxation techniques. You can suggest some relaxation techniques to those particular clients. And then in an event where one is already in an attack at home, what can they do other than taking drugs? Or if they have no access to drugs at that particular point, you can advise them to actually apply hot and cold compresses on the head, help advise them to sleep in a relaxed, dark, like in a quiet and dark room. Also, mostly those that would complain that I didn't have enough sleep, or it's lack of sleep that have developed this headache, let them have plenty of sleep. Not all the time that they need medication. Also, some small quantities of caffeine are very helpful. Just a drink of coffee, but the amount of caffeine, very important. They are supposed to be minimal, because remember we mentioned there that caffeine also is a trigger for migraine. but normally it is high content of caffeine that triggers. Small quantities are very much helpful. So you can advise them to have maybe a cup of coffee at home. Under pharmacological treatment, pharmacological management, of course, we talk about the medication that are actually involved, medications that we use in alleviating the symptoms or the attack of migraine. So we have NSAIDs, simple ibuprofen, diclofenac, naproxen, umofenamic acid can be used. Opioids such as codeine and tramadol, you can see that some formulations for migraine over the counter, they usually come with codeine in them with other molecules. Triptans is a very important group of drugs that we use to uh, manage migraines. In fact, triptans, they're believed to about 70% of migraine headaches. So very important amongst this. Then we have the ergot derivatives. These include ergotamine and dihydroergotamine, abbreviated as DHE. Then you realize that most people with migraine headaches, they also have nausea. Others can have vomiting. So antiemetics, very important to use in these ones. These antiemetics include metoclopramide, prochlorperazine, cyclizine, etc. Also worth mentioning is that a combination with caffeine in these medication that we've described above causes an enhancement in the absorption and also potentiates the effects of these particular medications. In people that have got the occurrences of migraine where the pattern is in such a way that it makes their living difficult, where the occurrences occur in a very short period of time, we can use drugs that are there to actually help prevent migraines. One of the common drugs is propranolol. That is, if it's not contraindicated in those particular people, because remember, propranolol is a beta blocker. So out of those drugs mentioned, I've decided to point out triptans because they seem to be more superior than the others by being able to handle migraine pain in about 70% of the patients. So just to say one or two things about triptans. So triptan, basically they are a class of selective serotonin receptor agonists. They actually stimulate serotonin receptors which inhibit the release of the vasodilatory peptides and substance P. These later is able to block the neurogenic inflammation, which helps to induce vasoconstriction of extracerebral blood vessels, including the cerebral blood vessels, hence reducing the dilatation of those blood vessels. Remember, the dilatation of blood vessels is the one which causes headaches. So these, they cause vasoconstriction and they're very much helpful. The examples of the triptans include sumatriptan, zomitriptan, rizatriptan, which are the fast onset. Whilst there is also a group 2 which is slower onset, which we don't have much on the market, and they are not used in migraine because of their slow onset, which renders them to be of lower efficacy. So another point to note about triptans is that they're contraindicated in pregnant and lactating women. More importantly, very much contraindicated in people with ischemic heart disease, people with pectoris angina. Remember that they cause extra cerebral blood vessel constriction, meaning that even the blood vessels taking blood to other parts of the body are going to be constricted, increasing the flow of making blockages in other cases. Therefore, they are very much highly contraindicated in those particular conditions that I've mentioned: ischemic heart disease, pectoris angina, and uncontrolled hypertension. So basically, or in summary, would say the management of migraine headaches includes one, to select medication for that particular client, because therapies are individualized, just like triggers to migraine are individualized. So when you're selecting a product for a particular person, you need to have a conversation with them so that you understand the patient's health history, you understand the response to previous therapies that I've used, and the onset of the effects. Also, the recurrent patterns, very important to also be able to help you make a decision which medication will be suited for that particular person. Use analgesic, simple analgesic for mild to moderate pain. Simple analgesics like NSAIDs, acetaminophen can be combined with like those products that come already combined with the NSAIDs and caffeine in them, or without caffeine, just a plain NSAID. For other people, they provide the relief. Like I mentioned, you have to ask about the history. For other people, they'll tell you, me, simple ibuprofen, it sorts my problem. Others say no, diclofenac. Others a combination. Others ibucap, rufedol, just like that. So simple ones, moderate or mild pain, you can use simple analgesics. Of course, an antiemetic can always be accompanied. Then for moderate to severe pain, most of the times you find NSAIDs don't do much. So triptans and the glutamine derivatives such as DHE can come in. Or you can combine either a triptan and an NSAID, but mostly a triptan on its own will be able to handle that particular pain. Then in severe cases, severe episodes, you need to make combinations, and that is where opioids also come in, because it means the other agents haven't managed to handle the case. So triptans, opioids, or a combination of one or two from above will be able to handle severe cases. Of course, antiemetics can also be combined, because I've seen most of the products for migraine, if they're specific, you realize that they come in combination with an antiemetic. Find there's a triptan and there's an NSAID, like the product called Vasograin. There you find the cyclizine, you find there's paracetamol, there's caffeine, and there's glutamine. Yeah, so basically these are the common therapies available that you can use. Of course, when someone has gone beyond the severe case, there are other agents that one would actually use, but these become referral cases because there is use now for sedatives or DHE, which is in injection form. These normally happen from hospitals, but it's just worth mentioning that these agents are actually used as in symptomatic relief of migraine. So this is just a summary of what I'm talking about. We're saying mild migraine headaches which last less than 2 hours. Let's use simple analgesics combined with an antiemetic. Moderate migraine, which is more than 4 hours, we can use triptan agents or together with an antiemetic. Combination with the analgesic wouldn't be a bad idea as well. Severe migraine, definitely you need triptans to be there. DHE, very important. Then in severe, which is severe migraine lasting between 6 to 72 hours, this is considered to be an emergency. If it has gone beyond that, they have taken these options that are available and there is no change, the pain is just unbearable, please refer. Because any migraine that is over 72 hours is referred to as status migrainosus, and that is a severe form of migraine. It really needs intervention at the hospital level. All right, so in conclusion, what are we saying? We are saying that migraine headaches, if they are going to be handled in a way that is going to be beneficial to a client, area identification, monitoring of the signs and the psychological stress, that is, we are talking about observing the triggers, being able to identify the triggers as early as possible and making an intervention is going to prevent acute attacks and prevent migraine to go into its severe form. I rest my case. Thank you very much for your time and stay blessed. These are the references to this presentation.